This is a sunset view off our deck looking at the north end of Lake Sammamish. Along the north end of this lake is a beautiful water ski course. When I finished the grad program, I had a goal to someday live close to this water ski course, and I invited Lisa Toms skiing here when she started as a graduate student 10 years ago, right, Lisa? Yeah. Several weeks ago, I'm on this course, going around a third ball. I'm late to ball 4, which means I had to really pull hard, head up on the horizon, screaming across the small ski nautique waves, traveling at over probably 40 miles an hour, headed to ball 5. I crash into this huge wakeboard wave, catapults me in the air, tip of my ski hits the top of the wave, flips me, I land on my back, wind completely knocked out of me. I'm in a lot of pain, my wife's driving. My second son lands, pulls me out of the water, calls 911. The good news is, I'm here today, surrounded by eagles. I'm honored to be speaking to you today. Lisbon, where Dr. Malo is from, who I learned from Nuno, was involved in the protocol for the Alumni Corps. This is my immediate family, except for my father-in-law, Jim, in Santorini, my oldest son, Chad, second son, Lance, third son, Troy, baby daughter, Gina, my beautiful wife, Victoria. Where's Waldo? Where am I? No, I'm not taking the picture. I'm at Evergreen Hospital, Washington, with a chest tube. When I hit the water, bam, I fractured 7 ribs, 5 along my spine, 4 along my side, 2 of the ribs fractured in 2 places, and 1 of those punctured my right lung, causing a moderate to large tension pneumothorax. That's why I had the chest tube. And if you have one of these, you can't fly because the pressure difference could cause the lung to collapse. So I was not able to join my family in this once-in-a-lifetime Mediterranean cruise. I told them, you go ahead without me, have a great time. So, I'm on my laptop. I emailed, I gotta get it, man. I emailed Lisa Toms. I tell her about my accident. I know how much she likes to ski. And she emails me back and says, oh, I had a great time on the water ski course in the morning, and that I should ski on a private lake where I don't have to worry about wakeboard waves. So I'm still on my laptop. I signed up to this slalom water ski course blog. My username is I Hate Wakeboard Those. This picture was taken by Bob Fauché. As you all know, he's got a lot of terrific pictures at bobfauchephotography.com. The magic of the picture that Bob took is that Lisa's smiling. And why is she smiling? Because she made it around ball 5 that I tried to get around. Philosophical statement Lisa's making is that to stay the course, you gotta make waves, baby. Anyway, skiing is a great release for me, but it can be dangerous and unpredictable unless you're on a private lake. I didn't anticipate crashing and spending 3 days in the hospital. The life is about making the most with the hand you're dealt, and you aren't always dealt a fair hand. Nicole certainly wasn't dealt a fair hand, but she made the most of it. This is Nicole. She's 34 years old. She was referred by Dr. Tanya Loving for an all-on course so that she can improve her oral condition and be employed as a dental assistant. She had a pretty rough childhood. Her dad was an international drug dealer. A teenage boy told her she was fat. She became a preteen bulimic. I told her, next time someone tells you that, tell them they're ugly and you can go on a diet. She recovered from bulimia nervosa and then became anorexic in her early 20s. She recovered from anorexia nervosa and then became a meth addict. At this point in her life, she became pregnant. Recovered, relapsed, recovered several times from her meth addiction. This case was published in Decisions in Dentistry, this past April's issue of the Journal of Multidisciplinary Care. I think Decisions in Dentistry is an excellent journal with a lot of good information on all disciplines of dentistry. Tom Wilson was editor-in-chief, or is editor-in-chief. He finished the grad Perry program in 1974. And John, I'll bet you know him. Marta Leone, I don't know her, but she's a graduate from our program, and she published an article 2 months after mine in June. So check it out. This case did involve multiple disciplines of dentistry, including myofunctional therapy and social factors that contributed to an extended treatment time. The path selected to get to a successful outcome clearly made it one of the most difficult cases I've treated since finishing grad program in 1985. It was technically difficult and extremely risky considering all the behavior changes required and the coordination of all disciplines for long-term success. I had failures and obstacles to overcome along the way, but nothing as bad as hitting a wakeboard wake at over 40 miles an hour. Speaking of 1985, I never thought of myself as an old guy, but I checked out the speaker roster and noticed everybody else graduated after I did, except for you, Ward. But some of the young guys in the room, they'd be asking like, hey, old guy, why do you have 2 laser pointers? Well, see. Stop, go, stop, go. No, just kidding. I really have ADD, attention deficit disorder. These help me get to the point. If you were to take these away from me, the rest of this presentation would be pointless. But actually, no, it's not a laser pointer, it's the world's smallest cell phone. And I'm on the phone with Keith Phillips. Keith! You're telling me the young guys don't want to hear from the old guys? Really? Click. When I say click, I'm putting Keith on hold. So take note, Philippe Kayat, my classmate, and Steve Chu. You know, really, you guys are icons. I think you just don't want it, you guys just don't want it from me. I think I gotta figure it out. Okay, I'm back off hold. Okay, Keith, you're telling me I've got to be rapid fire. I only have 20 minutes to give my presentation. I'm on rapid fire. I only got 20 minutes to give my presentation. I've got to talk really fast. Click. Oh my gosh. Okay, I think it's time for some Bob Cochet humor, right now? Okay, Keith, would you like the first part of my presentation or the second part of my presentation? Click. Okay, now I'm going to solicit your feedback. Based on how things have gone so far in this presentation, you probably want part 2, I'm thinking. But there's probably some single guys in the room that are glad they didn't miss a picture of Lisa skiing in part 1. Okay, I'm back off hold. Okay, Keith, I'm reflecting on my old age, and I'm going to really need an early speaking time so that I don't fall asleep. Click. And if I put you asleep, you can get a reprint from Nuno. Nuno? You have the reprints? Nuno? Nuno? Hi. Oh, no, I'm sorry, it's Michael. Michael has the reprints before break. Just pick one up if you fall asleep. Let's take, okay, part 2, right? Part 2, we're going to take a closer look at Nicole's mouth. In the upper arch, a lot of erosion, especially in the anterior region, classic of bulimia. A lot of restorations and decay in both arches, and clearly there is evidence here of a meth addiction. No evidence upper of altered passive eruption. The entire maxillary dental complex actively erupted to replace missing tooth structure in order to maintain vertical dimension with a normal freeway space. Her profile on the right is not that bad. The lower face is a little dished in from the lips lacking tooth support. She's missing tooth 2, 5, 18, and 30, the altered tooth positions and displaying of the anterior teeth are clearly evidence of a tongue crest. I have a pre-treatment video for end sound, and I want you to focus on the tongue in the beginning of the video. Don't listen to what she's saying. It was working before. Okay, you know, yay! Okay, here we go. Okay, so, boy. Okay, now go?
Yeah.
Hey.
I never thought that I'd have a nice smile that I could be proud of. Like after the dentist last year told me, you know, yeah, no, we can't do any temporary work. It has to be permanent. And I was like, oh my gosh, okay, pull them. And he was like, no, we can't pull healthy teeth. And I was like, oh, but they're my teeth. So can you just give me dentures?
So I don't know if the hecklers in the back row could see her tongue, but clearly she needs myofunctional therapy. Okay, models are mounted on a patented articulator, brought to the grad program in the early 80s by Bob Poche, still relevant today. Now that's the articulator is still relevant. Oh, Bob's still relevant too. Okay, I got a few laughs. Treatment began 6 months after initial evaluations with diagnostic records in order to establish a sustained recovery was possible. Her medical status is stable. She has gingivitis without any evidence of periodontitis. My daughter's point guard for the University of Idaho women's basketball team. Bear with me while I make a basketball analogy. Incidentally, her Division I team did win the Big Sky Conference. So Mad Dog Murphy, she beat both Montana teams. Anyway, no, back to this case was like starting a basketball game. Ward's checking his time. Okay. This case was like starting a basketball game with 4 fouls. She recovered from bulimia nervosa, foul 1. She recovered from anorexia nervosa, foul 2. She recovered from a meth addiction. How many people can do that? Foul 3. And now she's got to do myofunctional therapy in order to control her tongue while speaking and swallowing. Foul 4. One more foul and I'm on the bench. At this point, she's in control of her life and diet, and caring for her 11-year-old son as a single parent is helping with her accountability to avoid a relapse. You can hear me drinking water there. If we're going to avoid an all-on-4 or an immediate denture, there's some questions that we need to ask. Oh, that made me dizzy. Will extensive invasive treatment cause an addiction relapse? Well, that was a laser pointer. Can the natural teeth be saved? If we look at the anterior teeth, you can see there's a lot of erosion, and decay. Most of these teeth will require endodontic therapy, along with some of the other teeth will need endodontic therapy. Is it possible to do crown lengthening with an acceptable crown-to-root ratio? And, there goes the laser pointer again. Can we remove enough bone so that you will end up without a gummy smile? Well, if you look at the pan, the roots are really long, slightly tapered, perfect for crown lengthening and ending up with an acceptable crown-to-root ratio. And clearly, we can remove enough bone so that she won't end up with a gummy smile. And then lastly, is there enough bone to replace the 4 missing teeth with implants? Well, on this 2D, gobs of bone. And then the 3D cone beam reveals a lot of bone from the lingual to facial aspect also. So rather than all on 4, why not go natural with 4? I tried to sell this title to the editor, but he didn't buy it. So, and some state-of-the-art white wax, Models are sent to the laboratory to establish the position of the central incisors. TMJ range of mobility is within normal limits. There's no signs and symptoms of pathology. Here, profile, the lips are not balanced with the orthodontic S-line. We'll talk a little bit more about more of this in the future. The central incisors are toward too much to the facial, and the anterior teeth are over-contoured. A model is made from the diagnostic wax out. A stent is stuck down on that model, and you can see when she tries to smile, she has more gingival exposure above 6 and 7. So the wax up was sent back to the laboratory to increase the length of 6 and 7 apically. I made a new stent. This time I used a blue Sharpie, some more high technology, to outline the margins of the planned restorations. And you can see that you can see it more clearly in the mouth, but we still need another millimeter of length apically, and I did this at the time of performing the crown lengthening surgery. So if we look at the top margin of the planned restoration, you can see it's at or above bone level, which basically means we're going to have to remove a ton of bone, a crap load of bone. So this is before bone removal. After bone removal, you can see we've removed at least 4 millimeters of bone. And this picture really verifies what we saw in the panoramic film, which basically the roots are just slightly tapered. So we'll end up with, hopefully, with periodontal health and emergence profiles within normal limits. Preparations are complete. Finish line is well enough above bone for a healthy biologic width. The stent is coated with Vaseline, then lined with Visacryl, then seated by use of the hard palate. And the hard palate, of course, is your only point of registration. I could have used my NCXL milling machine and milled the provisional, but went old school in this situation. Are you ready for the reveal? Here it comes. She's got teeth. She's excited. She's jacked. She can smile. I think I had a little bit too much caffeine. But she stayed the course. She didn't crash. Of course, I didn't give her an oral sedation, an IV sedation, or any opioids to help avoid that crash. She only had local anesthetic and anti-inflammatories. The provisional, pretty good adaptation to that ankylosed healing abutment. The rest of the provisional would certainly not fit the parameters of Dr. Steve Chu's wonderful aesthetic instruments. I didn't tell Nicole that. At this point, she's done everything possible to succeed, comply. Dr. Tanya Loving orchestrated 4 people from her church to donate $20,000 for her treatment. These 2 pictures are more of the 4-day post-op. You can see we use interrupted sutures to put the facial and lingual pills back together. And if we look at the gums above this provisional, it looks like we have a pretty good potential for a healthy biologic width.
We have 10 minutes.
10 minutes. Okay, I'm going to start really fast right now. Okay, here we go. If you look at the provisional here, okay, now we're going to be critical, and that's what we do best. I'm speeding it up, man. Okay, the provisional buried in the lower lip. Excellent connection points to her shoulder, not her navel. They're over contour. When I submitted this for publication, there's 2 reviewers, double blind. They don't know me, I don't know them. One of the reviewers said, "How long did you leave her like that?" How long did I leave her? I should be shot. No. Well, you have to understand, she hasn't smiled for years. It takes months to evaluate provisional. Evaluate provisional, the smile line, and after 4 millimeters of bone removal, where are the gums going to end up? The next is another pre-treatment video for Enshelm. And in this video, I asked her to smile. You can see she has a hard time smiling, and when she does smile, all she shows are studs and gums. I couldn't put that in the publication. Give me a big smile. Pretend I give a great smile. You show a lot of gum tissue. Okay. This is a 4.5 month post-op. You can see the provisional has been modified for function, aesthetics, left side shorter, axial inclinations now are better. This is that orthodontic S line. You can see the lips are not balanced with that line, and better on the right. I'm gonna start faster. Deflection course placed, preparations, finish lines fine-tuned, impression made, central laboratory to fabricate medium translucency lithium disilicate restorations, jigs fabricated to control vertical dimension, number 5 ankylosed zircon. Sounds like something from Star Wars. Anyway, zircon ankle is abutment fastened to number 5 implant and modified. Same thing done to number 2 implant, only that abutment is titanium. There's 2 millimeters of tooth structure on top of the fibroclosed cord margins and the finish lines of those teeth treated endodontically. And the underlying tooth abutment color differences and the underlying implant abutment material differences will affect the color of the porcelain ceramic restorations as they're luted, along with the color of the cement and the thickness of the ceramic material. This study was done by John Coyce, 2011, JPD. There were 3 other authors. Is anybody in here part of that study? No? Okay. Resin was bonded to the incisal ledge in number 24-25 to control vertical dimension, while the posterior teeth are prepped. Pictures taken with the Omnicam. CAD design milled, stained glaze fire loaded in the morning. In the afternoon, deflection cords placed in the lower anterior teeth. The finish lines of 24-25 were close to the deflection cord in order to create emergence profiles somewhat within normal limits, while at the same time over-contouring those restorations to get a healthy papilla, which we don't have here. So we use the Omnicam to take pictures of the lower preparations, the finish lines outlined, and in this software version, if you set up the axial planes properly, you'll get a decent proposal. And that's what we did. Barely had to touch the CAD design, and then learn from Bob Fauché, waxing, that you wax to full contour, and then make the occlusive preparations and modifications for someone of that age. So in Nicole's case, the restorations are CAD designed to full contour, milled to full contour, then placed in the mouth in the blue state before firing, and then the occlusal wear pads and modifications are made for someone in their 30s. And you can see here between 24 and 25 that we may have a chance for a healthy papilla. 1 month later, 1 month post-op, we do, not that bad. But if we look between 9 and 10, we still have a Nordland class 1 papillary defect. And now it's time to address this surgically in order to restore that papilla. These 2 pictures look like they could be out of the 1992 International Journal of Periodontics and Restorative Dentistry. That was a journal that was really hot when we were classmates, right, Steve and Lulu? International Periodontics and Restorative. And this was published by Dr. Tarnell, Steve, your buddy. I appreciated very much visiting your office 2 years ago. You were very hospitable. It was an awesome experience. Tell Dr. Tarnell I said hello. Give him a reprint. I've referenced him 3 times. You too. Anyway, so Dr. Tarnell used this case presentation to augment a ridge. I'm going to use it to augment a papilla.
Tom, you have 5 minutes.
Okay, got a blooming This tissue is reflected, and then the underlying subepithelial connective tissue then is rolled and held by a suspensory suture around the composite bar. The composite bar is my idea, but Nordland last year in Compendium, he published an article and he uses the contact point to hold the suspensory suture. My personal feeling is you need the anchorage wherever you're going to move the tissue. And we've learned from Frank Spear over the years that the papilla is like a water balloon. If you press it in one area, it will expand in another area. So that's what we did. This tissue is coronally positioned, and then I use this retainer to compress it. Now the retainer's primary purpose is to control tooth movement while she's undergoing the myofunctional therapy. But in this case, I'm pressing it from the lingual and then pulling it with the vicral sutures tied around that bar on her facial. This is the holly bar from the retainer that rests above this composite bar. And this is the result in 3-month papilla improvement. I feel like this picture is pretty unique because it compares the same material fabricated 2 different methods. The material being the medium translucency lithium disilicate material, upper waxed, pressed, anterior layered, lower CAD designed milled, stained glaze fire coated in the morning. Anytime I'm doing a full mouth case, typically I like the cuspid to be the lowest value, highest chroma tooth in the mouth, sitting right next to the lateral incisor, which is the highest value, lowest chroma tooth in the mouth, and then the central incisors and the lower incisors, upper and lower posterior teeth, to be in the ranges of the chromas and values of the cuspid and the lateral incisor. Please compare the lower anterior teeth to the upper anterior teeth. I personally feel like the lower anterior teeth look more natural because there's more embrasure space gingivally and more embrasure space incisally. And you can see, if you focus on number 32, that I'm in the minimally invasive dentistry. That's just a small resin. Okay, thanks. You know, that's a classic Ralph Yodelis joke, right there. But if he would have said it, everybody would have laughed. Okay. Okay, you can see Nicole's done a fabulous job, meticulous job with her home care. If you focus on number 5, that's evidence of John Coyce's 2011 JPD study that ceramic color is not an exact science. And then if you remember the picture of the abutments, that ceramic zircon abutment is higher in value, low in chroma. Lisa, I think they're available in 2 colors, right? Dentin and neutral. I don't think I had Dentin in my inventory that morning. Okay, that's the final panographic film. We have 14 pressed anterior layer restorations, 15 CAD design milled on the bottom, 9 root canals, 4, 5, 6, 7, 8, 9, and 4 implants. I really like the ankylose implant system. It's coated on the top. You can see it's subpressily. It's a platform swish. 1 abutment will fit all the different sizes of implants. 4 different angles, 4 different gingival heights. I sound like I should be getting paid from Dentsply, but I'm just Joe Perry-O'Cross guy in the trenches. But anyway, I have 3 of them in my own mouth. They've been there for over 7 years. I'm a heavy clencher grinder. I took the crap out of my teeth. And so far, no screws loose. There's 1 loose up there, but I can't blame Dentsply on that one. But I'm really looking forward. I'm taking my whole office to Vegas first week in October to Zero World, sponsored by Dentsply. And there's one speaker that I really want to hear. Now that he has kids and a wife to keep him humble, he's funnier than ever. That's Jerry Seinfeld. This is a glamour. Would you shut up? This is a glamour picture of Nicole. My niece Lacey did her hair and makeup, very much of artist. She married Chris Larson, son of the late Arnie Larson, who did Ralph D's lab work and then Frank Spirit Vincent's lab work. He did Liofel staffing veneers. I have really dark tetracycline Steve. My bones are deep down. I'm really ugly. Don't tell my wife that. But he's a master with feldspathic and porcelain. To date, Nicole has not relapsed. She's thriving as a dental assistant in Kirkland, Washington. She entered the market at the perfect time because in the Seattle market, dental assistants are very much high demand. Nicole's been the most compliant patient I've ever worked on. She considered so much was done for her. She wasn't entitled in any manner. Meticulous oral hygiene, never missed an appointment, there early every day. And the reason for the case of success is her behavior changes that she made. Okay, this is I'd like to thank also Bob Fauché for his mentorship. Even though he retired from dentistry years ago, he's still sharing his expertise and knowledge with his former students, even probably for you, Ward, right? Yeah. And I'd like to thank the Perio faculty, along with John Townsend too. He's the glue for this program. When Ralph's on sabbatical, where's Ralph? Oh, John's here. Ariel's gone. Where's he? Oh, John's here. Anyway, thank you so much. Saul Schluger started the first program at the U. He started the first perio program at Columbia. But Stan Sapkos, they were great. I learned a lot from them. When I was in grad program, rightfully, all I wanted to do was cut gums and perio. But I'd like to thank also Lisa Toms. You donated 4 implants, 4 abutments. My Patterson Dental Rope donated 15 blocks. My laboratory. Yeah, I have, okay. Thank you for allowing me to present. I want to end in this video right now. Okay.
I'm self-conscious to talk to people. In my mind, I'm thinking, well, look at that girl with her teeth missing or half broken. I graduated from dental assisting school, and I put all that time and effort into graduating. I wanted to utilize that degree. No dentist is going to hire me with my teeth messed up like this. I just kind of let that dream go. I figured I'm going to end up working at McDonald's or something, but you know what? I'm going to share my story at church.
It happened on my birthday too. They called me and she goes, "You'll never believe it, I'm like, what?" She goes, "Somebody wants to help you fix your teeth." I was like, "Are you serious?" I thought she was joking. I never in a million years would have thought this was possible. And that just shows me how real God is. Honestly, I don't really have any regrets because even though I made poor choices, it got me to where I'm at today. And I don't believe I can get where I'm at today spiritually and in any way. If I wouldn't have made poor choices in my life, it just makes me who I am today. When patients come in now and they're talking about, oh, getting worse, that they're losing out.